Hello, my name is Stephanie Dunkle, and today we will be discussing Addison's disease. The objectives will be to demonstrate a better understanding of what Addison's disease is, describe what the impact on the community of Addison's disease has. We'll have a better understanding of the pathophysiology of Addison's disease, and we'll understand the signs and symptoms of Addison's disease. We'll discuss Addisonian crisis and understand the pharmacological and non-pharmacological treatment for Addison's disease. So what is Addison's disease? Addison's disease is a chronic adrenal corticoid insufficiency. There's a decreased secretion of the glucocorticoid, mineralocorticoid, and androgen hormones. The impact on the community is that it affects 120 people per million. There's a higher incidence in women than in men. It occurs most often in adults 30 to 60 years of age, and the most common cause of Addison's disease in the United States is the autoimmune destruction of the adrenal cortex, and it's the master of disguise. President John F. Kennedy had Addison's disease, and many people did not know that when he was the President of the United States. Another person that has Addison's disease in my life is my dad. There's a picture of my dad. A better picture of my dad with my mom. Notice his hyperpigmentation of his skin compared to my mom. Very dark. The pathophysiology is that Addison's disease is a chronic condition that results from the partial or complete destruction of the adrenal cortex. There's an overproduction of ACTH, the adrenal corticoid hormone, by the pituitary gland. With the overproduction of ACTH, there's a compensatory mechanism for decreased cortisol production by the adrenal glands, and this results in the decreased secretion of the glucocorticoids, mineralocorticoids, and androgens. Here's a picture of the adrenal glands. They sit on top of the kidney. Here's a diagram of the adrenal glands and the three main sections: the zona glomerulosa, the zona fasciculata, and the zona reticularis. The zona glomerulosa is responsible for secreting the mineralocorticoids. The adrenal, or the aldosterone, is produced by the mineralocorticoids, and it regulates sodium and potassium. The zona fasciculata is main purpose is secreting the glucocorticoids, and the glucocorticoids converts food into energy. The zona reticularis is responsible for secreting the androgens, which is the sex hormones, or testosterone. There's a decrease in the glucocorticoids. There's a decrease in the body's ability to convert food into energy. This causing fatigue and weakness and hypoglycemia. A decrease in the mineralocorticoids, there becomes a decreased secretion of the aldosterone, which causes hypotension. And aldosterone maintains the sodium and the potassium balance. With a decrease in the androgens, there's a decrease in testosterone, and testosterone is responsible for muscle mass, libido, and a sense of well-being. Subjective findings are things that patients would complain about are fatigue, weakness, anorexia, low mood and irritability, nausea and vomiting, muscle and joint pain, and the loss of pubic and axillary hair in women. Objective findings would be hyperpigmentation, hypotension, hypoglycemia, hyperkalemia, a low-grade fever, EKG changes with a prolonged PR and QT interval, bradycardia, weight loss, amenorrhea, and anemia. The causes of Addison's disease are primary and secondary. Primary causes would be an idiopathic atrophy, which is an autoimmune response, infection, hemorrhage, and metastatic disease, and secondary causes, which is the hypopituitarism. In Addisonian crisis, patients would complain of pain in the lower back, abdomen, and legs, and severe vomiting and diarrhea, severe hypotension. They would experience vascular collapse. They would have an increased potassium and a decreased sodium level. The gold standard in diagnosing Addison's disease would be a serum chemistry and a CBC, administering a PPD test, drawing a rapid ACT test, and this would establish adrenal insufficiency, a plasma ACTH, which differentiates between primary adrenal and secondary pituitary, and a CT scan of the adrenal gland. Pharmacological interventions would be glucocorticoid replacement therapy or hydrocortisone. It's the drug of choice. Patients are taught to increase their dose if they are ill or have diarrhea or have excessive sweating or fever, and physicians would consider adding prednisone if the patient is ill. Other treatments would be mineralocorticoid replacement therapy or Florinef, and this is given to replace mineralocorticoid deficiency and helps replace aldosterone. Pharmacological interventions that are in research are the androgen hormone replacement, and this so far has shown a positive effect on well-being and mood, particularly in women. Non-pharmacological interventions would be dietary increase of sodium to 150 milliequivalents per day, and increased sodium intake in the event of excess sweating or diarrhea. Patient teaching is the main key in Addison's disease, so you would want to teach compliancy in taking their medicine as prescribed, increase hydrocortisone in the event of an acute stressor such as illness, teaching regarding crisis and prevention, avoiding infection or being predisposed to infection, so good hand washing is key, and advising healthcare providers of your Addison diagnosis in the case of trauma and or surgery. So in conclusion, Addison's disease is a rare disease and is an elusive disease to diagnose. There's an insufficiency of glucocorticoid, mineralocorticoid, and androgen hormones. It's treatable once the disease is diagnosed, and patient education is a major factor in preventing crisis.